talk. It's based on randomized control studies, which we often do in journal clubs. Unfortunately, no PGs are here today. Oh, there are. Oh, Chippy is there. But I didn't see them. Okay. So I'm going to use three major papers for this. One is this new article just published, What is an Estimand, by this Brennan Cahan. The second is a BMJ article, What is an Estimand? This ICH is International Council for Harmonization. So just one few line on that. That is, everybody does research, and then they had to have a group we sit together and say how rules and regulations for research are done. There's the International Council for Harmonization of Research, and they have different parts of it. So they have also given a little primer in that, again by this Brendan Cahan. And the current NEJM, or not current, I think a couple of months ago, NEJM had this article, Statistics in Medicine, What is an Estimand? So this is from the New England Journal. So I'll be using some of these material for my talk. This is for the clerks. You have, let's say, somebody with anxiety. Suppose I tell the clerks, today is your end of posting. You may become anxious and then not feel like coming for your end of posting on Monday. So the people with the new treatment, let's say I give you counseling, cognitive behavior therapy, don't worry, you'll do well. And other people, I may give you some anti-anxiety medicines. And then I'm going to see how many of you do well in the exams on Monday. That's called a randomized control study. Why randomized? Because who decides who gets the counseling and who gets medicine? It is a random coin toss or some other technique of randomization. So this is called randomized control study. Pragmatic study is where you include everybody. You don't have too many exclusion criteria. Just real life. That all people come, you just give whatever counseling is possible, and then the other arm gets whichever anti-anxiety medicine the doctor decides. Whereas in explanatory studies, the typical RCTs which we do for our critical appraisals, the population is highly controlled. If you have depression along with anxiety, you're excluded. If you have some other psychiatric condition, you're excluded. If you're diabetic, you're excluded. That. So too many inclusion, exclusion. So that's highly controlled studies are called explanatory. The intervention is highly specified. The control is highly specified. How the outcome is measured is how. So it's called explanatory. So one is like a guinea pig situation. The other one is more like real life. But in truth, we can have in between, slightly pragmatic, slightly explanatory. So most RCTs probably won't be either completely pragmatic or completely guinea pig-like. So that's in between. There is a large amount of area which we can explore. That's what we are really going to explore today in this talk on Estimand. So let's ask the clerks. Have you heard of PICO before in research? P stands for the population you're studying. So here that population is people with mild anxiety. That's easy. I stands for the clerks, intervention and control. So the intervention here, they said, is 8 sessions of cognitive behavior therapy, and the control was anti-anxiety medication. So the I and C here. The outcome was, O is the outcome, and here it is anxiety measured by this HADS anxiety subscale. So this is so far so good. Normally when we talk, we say PICO TS, meaning time of the outcome. When I am measuring this outcome, here it's 12 months, and S is study design. But we're only talking about RCT. So there are two new things which people are talking about now, which all of us must learn. One is what summary measure you're going to do. This HAD subscale is a continuous scale. How are you going to measure that, express the difference in the two groups? Is it going to be risk ratio, odds ratio? I think the clerks learned risk ratio, odds ratio in community health posting. Our PGs also know that. Here they said that they're going to measure the anxiety in the CBT group, average anxiety in the medication group, and express the difference of means. What is the mean difference in the anxiety score? So one new thing with all of us get used to when you talk about PICO is, what is the summary measure? The last one is strategies to handle intercurrent events. So a lot of the talk today is going to be about intercurrent events, which we usually ignore when we are doing the intention to treat analysis. I'm not going to go into that because I'm going to explain that in detail. Intention to treat means everybody who's randomized is included in the final denominator. If I give you cognitive behavior therapy, what will happen to you? Whether you took the treatment or not, whether the person gave the the cognitive behavior therapy well or not is not the question. I assigned you to counseling, what happened to you? I assigned you to anxiety medication, what happened to you? But that I never took the medicine, or I took only half the dose, or I had side effect and stopped. I don't care. That is intention to treat. Per protocol is also called as treated, means I was assigned to CBT, I had 8 sessions, it was given to me properly, I came for the correct follow up. So only those people, all the good boys, are taken in the analysis. That's called per protocol analysis. So why did I get interested in this talk? Actually, I saw this article in August, New England Journal. This is a new weight loss drug, cagrilintide, and semaglutide is the usual drug which is given. These are adults without diabetes who are overweight or obese. So they had 4 arms. This is Cagri and this is Sema. Cagri plus Sema, Sema alone, Cagri alone, or placebo. Placebo means just a tablet which has some sweet or salt or chalk. So just want to just take you through one group. Let's look at this group, let us say semaglutide group. 304 people, of the 3,400 randomized, 302 took semaglutide alone. 26 discontinued, some due to adverse events, some didn't feel they're getting better, some were lost to follow up, one got pregnant, 3 said, I don't want to take part, 8 gave other reasons, and 12 withdrew. So you can say these are called intercurrent events. When you do intention to treat, you ignore all these intercurrent events. So you can, where is that marker now? Okay, I lost this. So these intercurrent events are generally not considered. But you can see there are so many intercurrent events in all the groups. In intention to treat, we just take 2,100, 302, 302, 705 as the denominator. What do we do with all these people who had intercurrent events? We say that they did well. Nothing happened to them. Their anxiety went away. Or some sort of good news scenario. That's intention to treat. So you can see that in each of these groups, 4 groups, there were a large number of people with intercurrent events. So this is the protocol for this study. The primary outcome was relative change in body weight. That means from baseline to week 68, expressed as percentage. How much of your body weight have you lost? They also did something called a co-primary outcome, because people couldn't agree on what is the primary outcome. They fought and they said, okay, let's have 2 primary outcomes. How many people had at least 5% of body weight reduction? So that is the count, the number of people who had 5% body weight loss. They also had secondary outcomes, and then they had a numerous list of secondary and tertiary outcomes. So usually this is something you must get used to for the PG, that you can have many interests and you can keep putting them as secondary and tertiary outcomes. We don't have to go into all of them. But essentially it is 5% weight loss, how many achieved 20% weight loss, 25% weight loss, 30% weight loss. So you can keep on doing those kind of analysis. Now, this is something that we are not used to, at least here when we present. The results are now called, the outcome is called the primary estimand. What is that primary estimand? It's called the treatment policy estimand. As I'll talk in a few slides, this is called intention to treat. But the new word is now called treatment policy estimand. So it's some mouthful of new words to learn. So this is, what is it? It is regardless of adherence to treatment, what is the outcome? Once you're randomized, what happens to you? Whether you took, didn't take, whether you ran away, withdrew, that doesn't matter. So the intention to treat is also called the treatment policy estimand. So a new word. So let us see the results. What was the percentage change in body weight? In the Cagri plus Sema group, they lost about 20% of body weight. In the placebo group, they lost 3%. The difference is 17%, which was statistically significant. That is the primary estimand, treatment policy estimand. What percentage of people lost 5% of body weight? 90% in the Cagri plus Sema lost at least 5%. Here it is 30%. So the placebo people also lost weight. Really weird. But the difference was 60%. This was called, so you understand how the 60% came now? I'm just showing it in a picture. 90%, 30% lost 5% of body weight. The difference between 90 and 30 is 60%. This is called treatment policy estimand, intention to treat. Now they also produced one more picture and said, no, there's another estimand called 70%. 70% looks better than 60%. And they call this trial product estimand. So this is a new trick in randomized control studies. So that's why I'm going to spend a little bit of time teaching about these new kinds of estimands which all these clinical trials are now teaching. So what is this primary estimand? What is a secondary estimand? The primary is intention to treat, which all of us understood, 60%. The secondary analysis, what happens to all those people who discontinued drug, lost to follow up, discontinued? Suppose they had taken treatment, what would have happened? Does anybody know? But if you do some sort of assumption, they believe that is 70%. If everybody, per protocol is only those who actually did. But here, everybody who discontinued, withdrew, what if they behaved well and did everything correctly? What would have happened? That they have called it as 70%, and they call this as a secondary estimand, trial product estimand. There are 5 types of estimands, and I'm going to teach you that. ITT for the clerks, regardless of what happened. Post-randomization adherence means after you're told you take in counseling, I don't want counseling, I want tablet. I don't care. Additional therapies. You are randomized to counseling. You take counseling and you take tablets. I don't care. Variation. Instead of 8 sessions of counseling, I go only for 4. I don't care. So intention to treat doesn't mind each of these. So you have a protocol. As long as you are assigned to the protocol, that's all ITT is about. So that's called real world effect. If I assign you to some treatment, what will happen? Whether it took or not, I don't care. So ITT is also called real world effect. So let us quickly list what are the intercurrent events. Patients may stop because they don't feel better. Hey, at the end of 3 months, I have not lost any weight. Why should I take this weight loss drug? Stop taking. I may decide to leave the study. I am going to Chennai. Left. I may withdraw consent. This doctor is not very nice. I feel a bit strange, like a guinea pig. I am withdrawing. I only go for 3 visits instead of 8. Incomplete data. Now, instead of this weight loss is not working, now I'm going to start taking this new diet. I was not supposed to try a diet change in the middle of these tablets, but I decided to try a diet as well. Rescue medication. Somebody died. Outcome wasn't death. Outcome was weight loss. But this fellow died in the middle of the study. He died. What to do with this guy now? All these are intercurrent events. What is the effect of having intercurrent effects? One is we can say that we'll ignore them. That's what ITT does. Or we can take them out of the whole story and do per protocol analysis. That's only those who are remaining who followed everything. Or we can incorporate them into the results. We have to make some assumption about what happened to them. And that cannot be refuted. I can say this is what happened. We need to say this didn't happen. So we cannot refute it. So we have to make some sort of a leap of faith as to what possibly happened. Let me give you some examples. Now for asthma, I was asking some of the clerks, tell me some antibodies for asthma. But none of the clerks got back to me who were in my room in the OPD. Anyway, dipolumab is one of the antibodies for asthma. So somebody is given medicine A for asthma, other person is randomized to dipolumab. Now the chap in the dipolumab starts taking rescue salbutamol. So now is the outcome because of dipolumab alone or dipolumab plus rescue salbutamol? Yeah, but the thing is when you do intention to decide, I don't care what else you do. Like I'm going to assume it's because of dipolumab. So there was an intercurrent event where somebody started taking rescue medication, but you also added that into your outcome. When you ignored that when you're doing intention to treat. Now, very often people come to the emergency department with some abdominal emergency. And now people are saying one is to give bolus 2 liters of fluid. Other people say, no, give little controlled amount of fluid. So somebody comes to the emergency, is very sick. He's randomized to get a huge amount of fluid or a intermittent amount. While this randomization is going on and fluid strategy starts, patient dies. But he's already randomized. Now, what to do now, this patient? He's in the large bolus fluid arm, but he's died before surgery. Or the family felt this man is going to die anyway, let us not have surgery, let's take him home. So what do you do in between? Before the treatment starts itself, people get withdrawn. Another example, this is a true story. Okay, now music therapy is a new thing. I'm sure, how many of you find music relaxing? Very good. So you randomize some old person with dementia, a grandfather, and say, you're going to have music therapy, and another grandfather is not going to have music therapy. And we're going to see at 90 days his memory. But the music improved his memory. Now your grandfather dies after 45 days. I mean, he can die, it's his right to die at whatever age, but now that's a problem now. You want to know memory loss at 90 days, but your grandfather unfortunately died at 45 days. So this is an intercurrent event which affects your ability to measure the memory loss at 90 days. So this is another example of intercurrent events. So there are 5 estimands. Remember treatment policy estimand? This is intention to treat. It's a fancy word for that. So investigators used patient outcomes regardless of whether they were affected by the intercurrent events. So we just ignore it. All those who are lost to follow-up did well. Don't worry about them. The second one is called composite. This is the second estimand is called composite estimand. Investigators would change the outcome for the event affected by the event and call it a failure. That means whenever you, for example, you took rescue salbutamol, now you failed. You didn't really fail, but that's what happened. Because something happened to you, you are called a failure. So this is called outcome, assigning participants who experience intercurrent event as an unfavorable outcome. It's a leap of faith. We don't know. But one thing is, hey, why did you drop out of the study? Because you're not doing well. So they are called failure. So this is now called a composite estimand. The third one is called while on treatment. The outcome data is up to the point the final event happened or up to the intercurrent event. So I only include you up to that time. Up to taking rescue salbutamol, what happened is what I'm going to count. Once an intercurrent event happens, I take you out of the study. So I'm only interested up to that time point. So this kind of an estimand is called while on treatment, meaning you have followed everything correctly. The moment you dropped out, we're taking you out of the study. This is called while on treatment estimand. The next one is called hypothetical estimand. This is outcome data after the event are not relevant. Investigators want to know what the outcome would have been if the patient had not been affected by the event. So in other words, hey, this patient dropped out. What would have happened to this patient if he didn't drop out? How do I know that? I have to use some statistical technique and say, yes, okay, patient X dropped out, but based on his baseline characteristics and based on X and Y, I can predict what would have happened to him if he didn't drop out. And then I do the analysis. This kind of analysis is called hypothetical estimand. So the common methods are assume that the outcomes of all random participants after the intercurrent events are not part of the target. And there are some methods. How do I know what happened to people who are lost to follow-up? One is called inverse probability weighting, multiple imputation, and some other models. These model assumptions cannot be tested because we really don't know what happened to people who lost to follow-up, people who took rescue medication, but we make some sort of a we don't tomorrow guess, I think this what happened. We use some statistical method. That estimand is now called hypothetical estimand. The last one is called principal stratum. Investigators use statistical models to try to identify which patients would not be affected by intercurrent events. Example, those who would adhere under the treatment assignment, and then compare outcomes within the subpopulations to those who would not be affected by the event. So this is a little more complicated method, principal stratum. You have to assume what is going to happen to those people if they should not have lost to follow-up. We need a lot of data before they lost to follow-up and data for them after they were lost to follow-up also to do this rather complicated one called principal stratum type of Estimand. Let's put all this into some story so that we don't let in theory. Okay, remember the story? You're anxious about the exam on Monday, you have cognitive behavior therapy, or you have anxiety medication. So the population are people with mild anxiety. The treatments are either cognitive behavior therapy or anxiety medication. The endpoint variable is, these are new things, PI and C. O is here, 12-month HADS anxiety score, and the summary measure is difference in mean of the anxiety score. This is the new point, summary measure. And what to do about intercurrent events is the story. The first one is treatment policy Estimand. What do we do here? Intention to treat. So we are ignoring that. The second one is the hypothetical Estimand. Effect of CBT if all patients fully adhered. We make some assumption. And the third one is this principal stratum Estimand. Patients with mild anxiety who would adhere to their assigned treatment, i.e. at least 50% of CBT sessions if assigned to CBT, and not receive CBT if assigned to medication. In other words, if I am given tablets, I shouldn't secretly go and receive counseling. That's principal stratum. So here the treatment is 8 sessions of CBT. Whether you took the 8 sessions of CBT or not, I am not bothered. In people with a hypothetical, 8 sessions of CBT without any anxiety medication versus medication alone, targeting the scenario where everybody is fully adherent. So you make an assumption in hypothetical that everybody is fully compliant, what actually happened to them. 8 sessions of CBT, anxiety medication as indicated versus medication alone. And the outcomes are the same. So this is the one aspect of this 3 groups. Now the second one, the same groups, what happened if people stopped CBT early? What happens in the ITT analysis? We ignore them. What happened in the hypothetical strategy? I don't care. I know what happened to you. I make some assumption about what happened to you in the future. In the principal stratum, the effect of those patients who adhere to both treatment assignments, that means at least 4 CBT is taken, and those who didn't take any treatment is taken. That is principal stratum. What about taking anxiety medication on the CBT arm? That means you crossed over. Crossover is a big problem. Hey, you are supposed to do this. No, I'll go and do that. So what happens to that? In the ITT analysis, we ignore those people. We are not very worried about that. In the hypothetical Estimand, no, you were assigned to this. What would have happened to you if you continued in that? You crossed over. I'll ignore that. I'll assume what would have happened to you if you stayed in that arm. Whereas in the principal stratum Estimand, treatment policy strategy effect regardless of whether the patient jumped into that arm. You have some minimum criteria to follow. The Estimand summary, that is the mean difference in the 2 groups, is the mean of the people you have in the intention to treat. Whoever is there, you take that as the mean difference. We can do some imputation for the missing data. Here in the hypothetical Estimand, we make some assumption. What would have been his anxiety score at the end of the study? So you have the mean difference because you put some value there. Whereas the Estimand in the principal stratum is a difference in the means at 12 months between 8 sessions of CBT with medication alone in patients who had at least 50% of CBT and those who didn't cross over. So you make some assumptions about that. The last one, what is the design implication? ITT, the only thing you can do is you try your best to make sure that everybody is adherent, follows properly. So you have a lot of training sessions for the doctors. You keep on telling the patients, please come regularly, have some phone calls, adhere properly. Now, in the hypothetical Estimand, we are to do the same thing, additional support, reminders, etc. But we are doing some statistical methods to see what happens to people who are lost to follow-up. But we're not, in this primary stratum, we're not really worried about it because we are only looking at people who took at least 50% of the CBT and all those who didn't cross over from medicine arm to take additional CBT. That's principal stratum. When you're doing analysis in ITT, we analyze everybody according to the arm that they were randomized. In the hypothetical analysis, analysis could be done by including all randomized patients, but censoring the outcome data at the time the intercurrent event happened. And then we try to see after the intercurrent event, we assume some value for those people subsequent to that. That is hypothetical. Here in the principal stratum, analysis could be done by including all randomized subjects according to their arm. In conjunction, we do some other analysis for them. Now, this is the document I told you about, the US Department of Health, ICH document revision 2021, how to do this principal analysis of estimands, what should be done and what should not be done. So there is a guidance document how we should go about doing this. So according to them, the primary estimand should be the one published in the paper, that is intention to treat. Whether you're doing Pope protocol or one of these hypothetical or anything else should be called sensitivity estimator 1, sensitivity estimator 2, because that is making some assumptions about what happened. So we must be clear that when you publish, this should be the abstract, this should be in the main text, this should be in the summary, which is intention to treat. All the other ones are called sensitivity estimators and could be published separately or in an addendum. So treatment policy estimand is intention to treat. We ignore intercurrent events, and it's also called ITT. So you may see some NEJM papers or top journal papers now calling it as treatment policy estimand. Don't worry, that is just a ITT analysis. Hypothetical is counterfactual values are imputed as if the intercurrent event had not occurred. This is different from per protocol, which is you take off all the people who didn't do it correctly and you keep only the remaining people. This is a hypothetical estimand, also called hypothetical estimand. So what do they say? First, you must mention the treatments which are being compared, which is the I and C. Population, which is the P. Endpoint, here is the anxiety score. Data summary, which is the difference in means. And the strategy for handling intercurrent events. So these are the 5 things which we must now get used to. PICO is here. Now we must start saying, okay, what is the summary measure and how did they handle intercurrent events? So just some to finally, not last 10 minutes. Estimand means what is the target question? What is the effect if everyone could adhere perfectly? That is called the estimand. Estimator is the method used. Here we can say ITT. What happened if everyone adhered? That's called the estimand question. The estimator, the methodology here is ITT. Estimate is the mean difference. That value is called. So you get used to these new, when you're reading these RCT papers, you get used to these new words which are coming up. Estimand, estimator, and estimate. So let's get back to our first example. Remember, I started off with that NEJM story of Kagri and Sema. Some participants stopped because of lack of weight loss. Some people had side effect, but they used ITT estimate. That means ignored all the intercurrent events. Investigators must continue to measure the endpoint, weight loss, after the treatment discontinuation. They took or not, you're trying to keep and compare all the endpoints for everybody. ITT, everybody understands. Now they have done something called trial product estimand. So remember, one of the estimands is called trial product estimand. So this is a hypothetical strategy. So remember that everybody has different words. Somebody said trial product estimand. Some other article called it a hypothetical estimand. The same thing. That means no participants have side effects that led to discontinuation. We make an assumption that everybody continue the treatment till the end of the study. So this paper has also published that trial product estimand, which is also called hypothetical strategy. The investigators discard endpoint measurements taken after discontinuation and you impute values for those people. This is an imagined scenario in which treatment was continued. So it requires a little leap of faith to believe this. So trial product estimand, anyway, I've spent a lot of time explaining trial product estimand. For this hypothetical scenario, all participants continue treatment throughout the trial period. All the participants who have side effects would nonetheless continue treatment. So in other words, even if you have side effects, we have to make assumption, I won't stop. Nobody's side effect will be so severe that the treatment should be stopped. This is slightly unethical that people will continue treatment regardless of side effects. And the second one is, this is some other formulation of the drug which doesn't have severe side effects, which is also not true. We cannot tell the patient, even if you have side effects, you continue. We can't assume that, hey, you got one form. Imagine you took a tablet which didn't have side effects. Neither of these are actually true situations. So it's a little bit of assumption. So it generates an estimate which hasn't been and probably couldn't be observed. That's the important thing about this hypothetical estimand. So this hypothetical trial product estimand is sometimes erroneously reported as the primary outcome. That is why I really want to take this session. Sometimes the pharma company will publish that, or the researcher, because that looks better than the ITT analysis. Because you can make an assumption that everybody did very well. So that's a very good thing. It's the practical concern. So unfortunately, when you want to do weight loss, everybody wants weight loss to happen. So you publish a trial product estimand or hypothetical estimand, so everybody is happy. So this ICH document offers a useful framework. What should you do? ITT analysis should be the primary estimate. They all say that. So when somebody does some other estimate, be careful. Find the ITT estimates. Side effects, adverse events should be fully reported. Okay. Anyway, so this is a summary of that. Back to the study. 2 estimands were used to study efficacy. Treatment policy estimand and trial product estimand. This is treatment policy estimand is also called ITT. Trial product estimand is also called hypothetical estimand. So all these, where did I get the details from? From the supplementary appendix. It takes a lot of time to go and dig out these things. And in that supplementary appendix, they put co-primary outcomes, secondary outcomes, and they have given one table like this. Now I want to spend some time in the table. This is the primary outcome. How much weight loss you had? Percentage weight loss. This endpoint is continuous. Either you lost 5, 6, 7 kilos or not. And the treatment policy or estimand is also called ITT. Trial product is hypothetical. For the treatment policy, they use the statistical methodology called ANCOVA. For the trial product, they use a statistical technique called MRM. And for the missing data, they use this multiple imputation method, which Elbin mentioned. And they've done some sensitivity analysis, meaning you can try different techniques also. Now, the second outcome is the same. How many people lost? 5%. Now, this is a number. Did 5% lose? 10% of people lose 5%? So that's a binary outcome. You lost 5% or you didn't lose. Treatment policy again, just to make jog everybody's memories, ITT. Trial product is hypothetical. For both of them, they use logistic regression. And for missing values, they use 2 different kinds of techniques, and they've done sensitivity analysis. So this is just a brief talk on Estimand and the new kind of things which people are publishing. Somebody studied this and saw that who will decide this? Ethics committees now will be looking at this. When you go to publish an RCT, you go to the ethics committee, say, I'm planning to do randomized control study. They will look at your analysis plan. And then they will recommend, hey, along with ITT, you should use this other Estimand methodology. So this particular group looked at central nervous system studies. What happened to people? How did they assess intercurrent events? This is a paper published by this Lisa Meszaros. It's a recent publication. So this was a strategy proposed by the authors. Treatment policy is ITT. And the strategy recommended by the ethics committee was again treatment policy. But it was hypothetical. They thought initially some people were suggested by the ethics committee to do a composite. So I'm just saying that this is a strategy to handle treatment discontinuation. So if you are expecting a lot of people to handle treatment discontinuation, the ethics committee may say, use this particular methodology. You may have some suggestion, but the committee may suggest some different one. If somebody takes additional therapy, hey, you're getting counseling, but you go and take extra medication, then you may say, I'll do treatment policy, but generally the ethics committees or the journals will say, do treatment policy. Some of them will say, why don't you also do principal composite or principal stratum type of analysis. If you have death, generally we stay with the some people will say, I will do a hypothetical where I'll assume the people who lost to follow-up died or didn't die. Okay, you may do the composite. You may continue to do hypothetical. Some people will say do a composite. Some people will do while on treatment strategy. So you can see that different people will recommend different strategies for handling these. During the pandemic, people are worried what to do now, like because numerous number of people were lost to follow-up during pandemic. So strangely at that time, many people did the hypothetical estimand. What would have happened? And many people reading the paper didn't realize that, hey, these people's data was not there. They made an assumption about death and published the paper. Whereas very few people planned treatment policy, and even people's recommendation was, okay, leave the treatment. That is actually the one we should really be looking at, treatment policy estimand. Okay, this is just like a different topic, slightly different from what we are usually used to. But this is a new thing. I saw the paper and what is this estimand? So I got busy reading this. Okay, any questions? Best case, worst case scenario type of hypothetical. No, intention to treat analysis is actually a best case scenario. In intention to treat, you can assume all the people who lost to follow-up did badly. That's a worst case scenario in an intention to treat. In hypothetical, use statistical technique to predict what would have happened to the person who was lost to follow-up. It's not assumed directly worst or best. You make some statistical methodology to assume what happened, not assume to calculate what happened to those people. In the ethics committee, you say that I am expecting loss to follow-up because weight loss drugs typically have a lot of side effects and a lot of loss to follow-up. So I'm going to use this strategy for the secondary estimands. No, based on previous literature, your knowledge of what is going to happen, you say, this is what I expect, so I'll publish this secondary estimands. For the clerks, just remember that, suppose I say that the drug will work differently in men and women. So I plan the analysis, I'll publish the full results, then I look at the results separately for men and women. Because I thought there's a difference biologically between men and women, and I planned it in advance, I call it a subgroup analysis. After the study, suddenly I find there's no difference. And I'm very mad. I spent a lot of money on this drug and nothing happened. Hey, let me now see if it worked differently in men and women. This is a fishing expedition. I'm trying to see something. I couldn't find out. Let me check if it's different in men and women, young and old. Now, this is called a sensitivity analysis. Sensitivity means I didn't plan it. But after the data was ready, that's what to Tina's question. After the study is over, you start doing a lot of different analysis. That's called sensitivity. That means I just am fishing around. Never change your clinical practice based on sensitivity analysis because people saw the data and they can decide to do all sorts of analysis. Okay, any questions online?